All right, let's jump right in. Today we're talking about a really tricky bug, Metamycoplasma hominis. This thing is a master of hiding in plain sight. It can be a harmless passenger in the body one minute and the cause of some really severe, tough-to-diagnose infections the next. For clinicians and microbiologists, it's a real puzzle. Yeah, this quote absolutely nails it. A formidable, opportunistic pathogen frequently missed. That's the whole story right there. This thing is an expert at flying under the radar in the lab, which means it gets missed at the bedside, and that can lead to some really dangerous situations. Okay, first things first, let's get the name right. A lot of us learned about this as Mycoplasma hominis, right? Well, back in 2018, a big study reclassified it. It's now officially Metamycoplasma hominis. And look, this isn't just some boring name change. It actually points to some really important biological differences that set it apart from its cousins in the Mycoplasma genus. So, here's how we're going to break it all down today. We'll start with why it's so underestimated, dive into the diagnostic headaches it causes, look at the serious illnesses it's linked to, unpack the treatment complexities, and finish up with infection control. All right, let's get into it. The biological paradox of this bug. So what makes this organism so special? Well, it belongs to a class of bacteria called mollicutes, which basically means soft skin. And that's the key. Imagine a knight without armor. Metamycoplasma hominis is born without a cell wall. And that one simple fact, it changes everything. It has huge knock-on effects for how we find it, how we identify it, and how we treat it. And here's that paradox in action. This bug is a classic two-faced operator. For a huge number of healthy adults, it's just there, hanging out in the urogenital tract, not causing any trouble. In fact, it's pretty common in situations like bacterial vaginosis. But, and this is a huge but, when it gets an opening, say a breach in the mucosal barrier during surgery or after childbirth or in someone who's immunocompromised, that's when it flips the switch from harmless commensal to dangerous pathogen. Okay, so if it's got this unique biology, you can bet it's going to be a nightmare for the lab. So let's talk about the diagnostic challenge. How do you even see something that's practically invisible? This is probably one of the most important takeaways for anyone in the lab or on the wards. You get a sample, it's full of pus, you do a gram stain, and you see nothing. Your first thought might be no bacteria, but you could be totally wrong. Because Mycoplasma hominis has no cell wall, the gram stain is completely blind to it. It just doesn't work. This is such a classic trap, and it can have some really serious consequences for the patient. And if you think, okay, I'll just culture it, well, good luck. This thing is incredibly picky. You can't just throw it on a standard blood agar plate. You need special, complex media, stuff that's packed with arginine. And then you have to be patient. Really patient. It can take anywhere from 2 to 7 days to grow. And if you're lucky, you'll finally see these tiny little colonies with that classic fried egg look. It's a ton of work, and you have to suspect it from the get-go. So that brings us to the modern diagnostic trade-off, and this is a big one. The good news? We have molecular tests now, NATs, like PCR. They are super fast, you can get an answer in hours, and they're incredibly sensitive. But here's the bad news, and it's a huge trade-off. You get the name of the bug, but you don't get the bug itself. There's no isolate. And without an isolate, you can't run susceptibility testing. So you know it's there, but you have no idea what drugs will work against it.
So you can see how this all adds up. These diagnostic challenges aren't just academic problems. They have real and sometimes devastating consequences at the bedside, especially when this bug decides to stop being a quiet neighbor and starts invading.
Yeah, you'll see it pop up in urogenital infections like PID. But the really scary stuff happens when it gets outside of that area. We're talking deep post-surgical infections, like after a heart operation. We're talking septic arthritis that can completely destroy a joint, even a prosthetic one, and even meningitis after brain surgery. But the absolute most catastrophic infections, those happen in newborns. And this right here is the nightmare scenario. Imagine you're on the neonatal unit. A baby comes in, septic. You do what you're trained to do. Start ampicillin and gentamicin, the standard playbook. But the baby isn't getting better. In fact, they're getting worse. This is where the alarm bell should be screaming. Why? Because Metamycoplasma hominis just laughs at beta-lactams. It's intrinsically resistant because it doesn't have a cell wall for the drug to target. That clinical picture, a septic newborn failing standard therapy, has to make you think of this bug.
Which, of course, leads us to the next massive problem. How do you even treat these infections? It's like navigating in the dark.
And here's something that might surprise you. If you go looking for detailed, specific treatment guidelines from major organizations, say the Dutch swab guidelines, you're going to come up empty-handed for Metamycoplasma hominis. They just don't exist. Clinicians are pretty much left to piece it together, inferring what to do from guidelines for a whole syndrome, or worse, relying on scattered case reports.
So for adults, the toolbox is pretty small. Doxycycline is your go-to for most urogenital stuff. If you're dealing with a bone or joint infection, clindamycin is often a good bet. And then you have the fluoroquinolones, like moxifloxacin, but you're really supposed to keep those in your back pocket for severe infections or when you know you're dealing with resistance.
But treating newborns? Man, that is a whole different level of difficulty. It's a genuine dilemma. The drugs that work best, the fluoroquinolones, the tetracyclines, are the very drugs we try to avoid in babies because of toxicity concerns. So you're in a terrible spot. You've got a baby with a life-threatening infection like meningitis, and you're forced to use these drugs off-label, weighing the potential harm of the drug against the almost certain harm of the infection. And you're making these calls based on just a handful of case reports. It's incredibly high stakes.
And just when you thought it couldn't get more complicated, it does. The way we interpret susceptibility results isn't even standardized globally. Think of it like this. In Europe, UCAS gives you some data, but it's more for tracking trends, not for telling a doctor use this drug. But in North America, CLSI gives you clear-cut, susceptible, intermediate, or resistant breakpoints. So the exact same bug with the exact same MIC value could get a different report in a lab in Amsterdam versus one in Boston. It's a real mess.
So let's wrap up by talking about infection control and what we can do to prevent this.
Okay, for my fellow lab folks out there, this is non-negotiable. Metamycoplasma hominis is a risk group 2 pathogen. That means all work has to happen in a BSL-2 lab. And anytime you're doing something that could create an aerosol, vortexing, pipetting, it absolutely has to be done inside a biological safety cabinet. No exceptions. Protect yourselves.
But the risk isn't just in the lab. There's a really sneaky route of transmission in the hospital that we don't talk about enough: contaminated tissue grafts. There have been documented outbreaks of horrible post-op infections that were eventually traced all the way back to an allograft from a donor who was colonized. It's a huge blind spot in our screening processes and a big reason to be extra suspicious when a post-surgical patient isn't getting better on standard antibiotics.
And this really leaves us with a big, looming question for the future, doesn't it? We're all moving towards faster molecular tests, which is great. But in doing so, we're losing our ability to see. We're giving up the isolates. So as we rely more and more on these culture-independent tests, how on earth are we going to track resistance in a bug that's already so hard to treat? How will we know when our last-line drugs are starting to fail?
We put all this information together using a Gemini deep search. If you want to dive into the primary literature yourself, you can find a full list of all the references in the notebook document that goes along with this. And hey, if you found this breakdown helpful, do us a favor and subscribe to the channel. Even better, jump into the comments below. We'd genuinely love to hear about your own experiences. Any tough cases or diagnostic challenges you've had with Metamycoplasma hominis. Thanks so much for tuning in.